And now I'd like to turn the podium over to Ron Ganellen, president of the Society for Personality Assessment. Ron received his PhD from the University of Miami in 1983. I bet you wish you were there now. He's been an SPA fellow since 2001. Ron published his first journal article in JPA in 1981, and since then there have been many more. And most recently, Ron has undertaken some significant editorial work as well. He's now helping to edit a special section of JPA on personality assessment in the diagnostic manuals, a timely topic if there ever was one, and one of the core assessment themes initiated by Steve Huprick when he took over as JPA editor. As you know, Ron Ganellen has a long history of leadership in SPA, including being a member of the Board of Trustees for several years before he was elected president. And I know that Ron has a number of ideas and initiatives he'll be presenting to us today and implementing during the coming years. So let me turn the stage over to Ron Ganellen.
I'd like to welcome everyone, all old friends and new friends, to Brooklyn for SPA this year. It's wonderful to see so many people here, and I just want to tell you a little bit about where we're going to be in the next couple of years, because we have a lineup that I hope everybody will be happy with. Next year, SPA will be meeting in Chicago, which will be wonderful for me since that's where I live. The year after that, we're going to be in San Francisco, and the year after that, we're going to be back in Washington, D.C. So there are a number of places that we'll be that I think will be terrific cities to be in to have our annual conventions. And we have Bill Hare, our travel consultant, to thank for that. There have been some transitions in SPA in the last couple of years, and one transition I think is very significant and that we'd like to acknowledge today, and that is that Jed Yaloff, who's been the editor of the SPA Exchange for the past 12 years, is stepping down. So I'm sure many of you enjoy getting the SPA Exchange when it comes out, reading the articles, learning about the activities in SPA. Jed has made this work seamlessly. He's made his job as editor look effortless. We're certainly going to miss him, and I'd like to call Jed up to give him an award. So Jed. Do you want to come up? Thank you. There have been several losses in personality assessment in the past several years. And one of the figures who has passed away this past year that we wanted to acknowledge, of course, is Ted Milan. And there will be a session honoring his memory and his legacy during the course of this year's convention. We are also saddened by the loss of Sid Blatt, which we announced at last year's convention. And one of Sid's students will be talking, giving one of the master lectures, which I'm very excited to hear about. In addition to that, there was a loss this year of Harrison Goff, who made significant contributions to the field of personality and personality assessment. He died last May at the age of 93. I'm going to read you a little squib from the obituary in the APA Monitor. And so one of the significant contributions that he made while working at the University of California at Berkeley was to develop the California Psychological Inventory. He also was very involved in creating the interpersonal dependency inventory. And I just wanted to read this quote from that describes him that I think is really eloquent, which is that Harrison Goff leaves a remarkable legacy of dedication, creativity, and impeccable professionalism, as well as extraordinary contributions to the field of psychology. He was the quintessential empiricist, and his view on measurement was always utilitarian and pragmatic. Does the measure work to predict external criteria? His empiricism presaged the contemporary recognition of the power of big data and quantification, and his pragmatism puts him at the core of 20th century psychology. And on a personal level, his legacy is one of kindness, intelligence, charm, and wit. He was, to so many people, the epitome of a true gentleman and a scholar. So that's our acknowledgement for Harrison Goff. There is also, I'm saddened to report that there was the death of a local psychologist, Giuseppe Cosentino, who was well known to many people associated with SPA. He's best known as the author of the TEMAS, T-E-M-A-S, the Tell Me a Story, a series of culture-specific picture sets used as stimuli for storytelling assessment of children. Dr. Costantino was the author of more than 5 books and over 50 book chapters and scientific articles on subjects of multicultural psychology. For those of you who were students, colleagues, or remember him, there will be a remembrance on Saturday evening at 7:30. Details about that can be found in the program or at the SBA help desk. So we just wanted to honor his legacy as well. So at this point, I'd like to talk about, as I was thinking about what I would talk about, it occurred to me that there are a number of themes that I could talk about and present to you that would awaken, I think, a lot of perhaps interest and empathy and curiosity. The first is I think the struggle between man's struggle for futility, between futility and for hope. For those of you who are not familiar with the concept, that white stuff there is snow, which is was up to about here, so I was a little tired of that. So another theme that I thought about talking about today involved man's struggle for authenticity and finding the true self. But I decided instead to talk about something else. And that is, that was triggered by getting a phone call several months ago from a former colleague of mine, a psychoanalytically oriented psychiatrist. And we'd worked together in the past on an inpatient hospital consultation liaison service. We'd both left the hospital, and his practice focused on psychoanalysis and psychoanalytic psychotherapy, while my assessment practice evolved to provide personality and neuropsychological assessments. We'd had sporadic contact, but had not worked together for some years. Mike said he'd been seeing a patient in intensive psychotherapy for a little more than 2 years. While the man who I'll call Joel had benefited from treatment, Mike, the psychiatrist, felt there was a piece of the clinical puzzle missing. In particular, he described Joel, a man in his late 30s, as showing a lot of potential, but having trouble performing as well as expected. Mike had approached the treatment from the perspective that Joel was handicapped by conflicts concerning success. Joel was clearly frustrated and distressed about the difficulties he'd had and was receptive to Mike's interventions, but little change in this area had occurred. Mike recalled that the psychological evaluations done by myself and the trainees I supervised on the CL service had answered questions in some challenging cases in the past and wondered if an evaluation might be helpful in sorting this out. Now, Mike is a sharp, seasoned, sophisticated clinician. For him to call me because he was stuck about a case was significant. When I agreed to see Joel, I anticipated that this would be a challenge. Joel was eager to get together to meet. When I introduced myself to him in the waiting room and invited him to come into my office, My first reaction ran along the line of wondering how he could have any problems in his life at all. He was, as the saying goes, tall, dark, and handsome. He had a winning smile and conveyed a sense of being self-confident and self-assured, with good reason. In terms of his academic background, Joel had earned a law degree from a top 10 law school and then earned an MEA from a prestigious program. Rather than practicing law, Joel became a consultant with a large consulting firm. After being there for about a year, the partner under whom he worked told Joel that he was puzzled by him. The partner explained that, on the one hand, he saw Joel as being bright, creative, hardworking, and personable with clients. On the other hand, however, when given a project, Joel would start out strong, but would falter and at some point would seem paralyzed, unable to take the next step without being prompted or given direction. In addition, although Joel could present his analysis and recommendations clearly in meetings with the team he was part of, the partner expressed concerns that Joel's presentations in client meetings had been unclear and disjointed, particularly when he responded to questions rather than following the material he had prepared. The partner said this was unexpected given Joel's level of experience and his standing in the firm. Joel commented, "That's the story of my career." Joel has worked at several consulting firms since then. He described his performance in these companies as being mixed. While Joel has had some clear successes, similar issues concerning completion of tasks, making decisions, and staying on point in meetings have come up repeatedly. It's happened several times that a manager or coworker has stepped in to complete work assigned to Joel when a deadline was fast approaching. He worries that his current position may not be secure because of these issues. As Joel put it, the problem is this: I have great credentials and drive. I want to succeed. Even though I work evenings and weekends, things don't always get done. I question if I keep putting myself in situations I'm not capable of doing. I commented that Joel conveyed very clearly both how much he wanted to succeed as well as how frustrated and discouraged he was that he continued to struggle with these difficulties. I asked Joel how he understood the issues that held him back. He replied that one important component of his work requires him to prepare written reports presenting his analysis of clients' problems and recommendations to solve the problems. Joel said he can think this through and have ideas set in his mind, but feels blocked when he tries to put his conclusions and recommendations on paper. He's wondered if he has a processing problem affecting his ability to write. So I asked Joel to describe the processes that affect his writing. He explained that while he's writing, he'll see a hole in the material and the argument he's trying to make, and realize he has to add material to fill in the hole. At some point after he goes back to edit what he's written, he starts to feel lost. Joel has noticed that while he's trying to write, an internal voice questions whether his work is good enough. He added to this, "And I get bored easily." Another issue Joel identified that affects his work involves his need to be independent. He sometimes feels put off and resentful if a manager gives very specific directions or if he feels that he's being micromanaged. It puzzles Joel that he sometimes can't finish work without guidance, while at other times he bristles when too much guidance is provided. As he put it, "With my personality, I don't like to be told what to do. I like to figure it out. But after I figure it out, I don't want to do the work. The process of figuring it out interests me. The process of doing the work doesn't." As a result, Joel frequently puts off starting to work on some assignments. I'd initially planned to administer a standard personality evaluation, a traditional battery of tests consisting of the WAIS-4, the Rorschach, and the MMPI-2 to address these issues. This seemed reasonable given Mike's suggestion of a conflict between failing and succeeding and the themes that Joel had presented of anxiety about being evaluated. Self-doubts and feelings of inadequacy, mixed reactions related to his need to function independently on the one hand, and feeling lost without guidance on the other. As I processed what Joel told me during the clinical interview, however, I was struck by other issues he'd identified, and these included a tendency to procrastinate, a tendency to get bored easily, a tendency to get derailed or disorganized when interrupted, and difficulty organizing his thoughts. These issues suggested another possibility: difficulties with attention, organization, and follow-through as a function of attention deficit hyperactivity disorder. With this possibility in mind, I inquired about the issues suggested of ADHD. When I asked Joel if the tendency to become bored had been true before he started working, for instance, he said that had been characteristic of him since he started school. Joel recalled that teachers consistently gave feedback about his school performance along the following lines. They said I was bright and creative, but I wasn't very organized or focused. He often felt restless in classes, fidgeted, and daydreamed. When he had to do tasks that required sustained attention, such as reading or writing papers, Joel's attention wandered and he would get up before he had completed the task. In addition, it was characteristic of him as a youngster to procrastinate. The difficulties Joel reported could be conceptualized in terms of anxiety and psychological conflicts, as Mike had suggested, or in terms of neurocognitive processing deficits associated with the inattentive type of ADHD. So the question then is, what do the data say? Do the test results provide support for these frameworks? So I'm going to first present some selected test data. If you take a look at just some of the cognitive data that's here, you can see that Joel is a pretty bright guy, is functioning in the superior range of intelligence, not surprising given his academic background and how well he'd done in school. So his cognitive processing looks to be pretty good. I'm also going to discuss a little bit about his MMPI-2 profile, which unfortunately did not make it into my PowerPoint presentation. It's a complex profile with the highest 2-point code being a 2-3 or 3-2 pattern, followed very closely by scale 7. So I'm going to present some of the descriptions of a 2-3-3-2 code type that comes straight out of Dr. Graham's MMPI book, which I've used ever since graduate school. So I have to say it's a great honor to have Dr. Graham here and to look forward to hearing the lecture he's going to give shortly after I'm done. So as described by Dr. Graham, the 2-3-3-2 code type indicates that Joel's mood involves a mixture of worry, tension, and unhappiness about his current situation. In general, he's someone who is invested in success, achievement, and status. In other words, Joel is an ambitious guy. We can speculate that the emotional distress Joel experiences is related to a sense of disappointment and discouragement about the difficulties he's had in reaching his goals. Another characteristic associated with the 2-3 profile is a coping style based on maintaining control over emotions. Joel typically responds to stress by trying to contain, suppress, or ignore negative feelings. Given the amount of energy it takes him to maintain control over his feelings, suggests that he may be, as Dr. Graham put it, emotionally bottled up, and he may feel tired and drained by the effort he expends. There's one sentence in Dr. Graham's 2-3-3-2 interpretation that struck me as ringing very true in Joel's case. And I'll just quote the sentence, which is, they, meaning people with the 2-3 code type, often feel they do not get adequate recognition for their accomplishments, and they're easily hurt by even mild criticism. The reason that struck me as being so true of Joel is because it highlights that one factor driving Joel's need to succeed is his desire to be recognized and respected. At the same time, he can be rather sensitive to even mild criticism. This suggests that Joel is motivated not only to seek approval, but is also motivated to avoid acting in ways that would lead him to feel embarrassed, ashamed, or criticized. Adding elements from the 2-7 code type indicates that disapproval activates Joel's feelings of inadequacy. When this happens, Joel is likely to devalue his abilities and accomplishments and engages in distressing negative rumination about his worth and his potential to succeed. This may be a recipe for inefficiencies in thinking, difficulties making decisions, and avoidance of situations in which there's a chance he could fail. So as moving back to the cognitive testing for a moment, Joel, as the testing indicates, is very strong cognitively, and he, I should mention, had a very particular strength in terms of conceptual reasoning, as he had a similarity score of 15 and matrix reasoning score of 16. But the most striking finding from his evaluation involves findings of significant difficulties focusing and sustaining attention shown on the Conners Continuous Performance Test. While Joel made few errors, his performance was notable for rapid speed of responding and greater than expected variability in reaction time. Response speed was less consistent and more erratic than expected and slowed across trials. In terms of which direction the data point to in order to understand Joel's difficulties, there is support for framing his problems in terms of his psychological dynamics, as well as in terms of weaknesses associated with the inattentive type of ADHD. While it may be tempting to approach an evaluation in terms of determining whether an individual's problems are due to psychological factors, such as anxiety, as opposed to ADHD, Joel's case illustrates that an either-or approach often does not fully account for the complicated issues which can affect performance, hinder progress towards reaching goals, and affect a person's sense of self-worth, competence, and agency. Stated differently, framing the goals of an evaluation in either-or terms may shortchange our understanding of an individual. I've presented this case about Joel, about this individual person, in considerable detail to make the point that an evaluation in which ADHD is suspected should not automatically focus exclusively on neuropsychological issues. In some cases, even many cases, evaluation of neurocognitive functioning may address the clinical questions asked by a referral source. However, personality assessment is often valuable when evaluating an individual with ADHD, not just in the service of determining whether the person's issues are due to ADHD or psychological factors, but because both set of problems may be present. In other words, ADHD is often comorbid with other psychological disorders. We now know that adult ADHD occurs frequently. This was shown in the National Comorbidity Survey Replication Study. The NCSR was a nationally representative household survey that examined the rates of a number of psychiatric disorders in roughly 3,200 adults between the ages of 18 and 44. The NCSR found that 4.4% of their sample was diagnosed with current adult attention deficit disorder. To put this in some context, according to the one-year prevalent estimates contained in the DSM-4, roughly 8 to 10% of the adult population meet diagnostic criteria for major depression. 3% of adults in the general population are diagnosed with generalized anxiety disorder, and 2% of adults are diagnosed with panic disorder. So these figures indicate that adult ADHD is not uncommon. To give you an idea of the scope of this problem, applying the estimate that 4.4% of the US general population meets diagnostic criteria for adult ADHD, currently more than 14 million adults have adult ADHD. Interestingly, of the adults diagnosed with ADHD in the NCSR, 75% had never been diagnosed with ADHD by a healthcare professional, although many individuals had been treated for other psychiatric problems such as depression, anxiety, or alcohol abuse. 75% had never been diagnosed with ADHD. Of the adults found to have adult ADHD in the NCSR, only about 11% had been treated for adult ADHD. Turning that around, what that means is 89% had never been treated for adult ADHD. This suggests that although the prevalence of adult ADHD is significant, adult ADHD is a condition that is frequently underdiagnosed and, as a result, is frequently untreated. Think for a moment about the adverse effects associated with ADHD in adults. The literature clearly documents that ADHD, particularly untreated ADHD, has significant adverse effects in terms of major life activities, including performance in school and occupational settings, level of income, contact with the legal system, financial management and decision-making, establishing and maintaining personal relationships, and functioning as a parent. Compared to adults without ADHD, adults with ADHD complete fewer years of school, change jobs more frequently, earn less, are more likely to get into trouble with the law, and are more likely to have disruptions in their personal and intimate relationships. Since adult ADHD can have significant social costs, it is somewhat astonishing that ADHD is so often unrecognized. As I said a moment ago, 75% of the adults diagnosed with ADHD in the NCSR study had never been diagnosed by a healthcare professional with ADHD. Extrapolating to the general population, that indicates that there are currently more than 10 million people with ADHD who have never been diagnosed. Furthermore, of those diagnosed with adult ADHD in the NCSR study, 89% had never been treated for ADHD. While it's reasonable to assume that some of these folks were not diagnosed or treated because they were well-adjusted and functioning effectively, it's also reasonable to assume that some were not. This is a sobering finding which highlights an important need for assessment psychologists. The NCSR also examined rates of comorbidity in adults with ADHD. The literature shows that individuals with adult ADHD quite frequently also meet DSM-IV criteria for other diagnoses. Estimates indicate that 50 to 75% of adults with ADHD also meet diagnostic criteria for another psychiatric disorder. To put that into some context, recall that the NCSR estimate is that approximately 14 million adults meet diagnostic criteria for ADHD, and of these adults, 7 to 10 million also meet diagnostic criteria for at least one other psychiatric disorder. We're all aware that there is an increased risk for alcohol or substance abuse disorder for individuals with ADHD. The NCSR estimated that 15% of adults with ADHD had a comorbid alcohol or substance abuse problem, while only 6% of adults without ADHD had a substance abuse problem. The NCSR also examined the co-occurrence of ADHD and other psychiatric disorders. They reported that 38% of adults with ADHD had a coexisting mood disorder, a mood disorder being defined as a major depressive disorder, dysthymia, or bipolar disorder, while only 11% of their control sample had a mood disorder. To break that down just a little bit further, the NCSR found that 19% of adults with ADHD had a comorbid major depression, compared with 8% of those without ADHD, and 13% of adults with ADHD had dysthymia versus 2% of controls. 47% of adults with ADHD were also diagnosed with some type of anxiety disorder. generalized anxiety disorder, post-traumatic stress disorder, panic disorder, or phobia, while only 20% of those without ADHD had an anxiety disorder. The most common anxiety disorder diagnosed in adults with ADHD was social phobia. 29% of adults diagnosed with ADHD also met diagnostic criteria for social phobia versus 8% of adults without ADHD. One very interesting area of psychopathology research has the goal of identifying psychological processes that underlie and cut across diagnostic categories. Traditional approaches to studies of psychopathology have investigated categories of psychopathology, such as schizophrenia or bipolar disorder, that are rationally or theoretically defined. In contrast, transdiagnostic research uses empirical approaches, such as factor analysis or cluster analysis, to determine the underlying latent structure of disturbed psychological functioning shared by patients regardless of the traditional diagnostic category to which they're assigned. And one of the names that's associated with that is Bob Kruger from the University of Minnesota. Results of transdiagnostic research to date identifies two major dimensions of psychopathology: disorders described as involving internalizing psychological processes and disorders involving externalizing psychological processes. This distinction between internalizing disorders and externalizing disorders is probably familiar to most of you as it parallels Achenbach's work with children. So internalizing disorders encompass mood disorders such as depression and anxiety disorders, whereas externalizing disorders encompass acting out behavior such as conduct disorder, antisocial personality disorder, or alcohol and substance abuse disorders. This is a very broad distinction. Internalizing and externalizing disorders is a very broad distinction. What's fascinating about this, in relation to adult ADHD, is that the stereotype, at least the stereotype that I hold, of someone with ADHD is of someone who gets into trouble because of their behavior. Someone who quits their job impulsively, someone who gets into fights, or someone who drives recklessly. These are all thought of as being part of the externalizing dimension of psychopathology. And of course, this stereotype is based on hard evidence. As we talked about before, ADHD is associated with alcohol abuse. ADHD is also associated with increased risk for conduct disorder in children, oppositional defiant disorder, antisocial personality disorder, and as I said, alcohol and drug abuse disorders. Studies estimate that 30 to 40% of adults with ADHD are also diagnosed with antisocial personality disorder, and approximately 15 to 30% of adults with ADHD are diagnosed with an alcohol-related disorder. However, and this may seem counterintuitive, the research that I've presented indicates that adult ADHD also carries an increased risk of internalizing disorders. As I said a few minutes ago, according to the NCSR, 38% of adults with ADHD have a mood disorder, and 47% of adults with ADHD have an anxiety disorder. Both of these are considered to be internalizing disorders. To summarize this, one, current research has found that 50 to 75% of adults diagnosed with ADHD are also diagnosed with another psychiatric disorder. Between 15 to 40% of adults with ADHD have an externalizing disorder, while roughly 30 to 50% of adults with ADHD have an internalizing disorder. In other words, there is a high degree of comorbidity associated with ADHD, and the comorbidity cuts across the domains of internalizing and externalizing disorders. There are certainly individuals with adult ADHD who have what might be considered a pure form, that is ADHD alone without any other comorbid disorder. According to the NCSR, 25 to 50% of the sample were diagnosed only with ADHD. That means that these are folks who, if they come for treatment, are going to come to treatment because they experience difficulties in functioning due to problems with attention, organization, time management skills, or self-control. It's also certain there are adults with ADHD, adult ADHD, who have these issues as well as other issues associated with comorbid disturbance. I'd like to suggest that we differentiate between these two groups. To borrow some terms from the PTSD literature, I suggest we differentiate between simple or uncomplicated adult ADHD and complex or complicated adult ADHD. Adults with ADHD alone would be viewed as having simple or uncomplicated adult ADHD, while adults with ADHD plus one or more other psychological disorders would be viewed as having complex or complicated adult ADHD. I think that this distinction has important implications both for treatment and for assessment of adult ADHD. Individuals in the uncomplicated ADHD group can benefit from treatment targeting specifically ADHD-related symptoms that cause problems in their lives. Treatment could involve stimulant medication and behavioral strategies to improve focus, attention, and follow-through. Treatment for individuals with complicated or complex PTSD naturally is, well, more complex. Treatment would target problems due to ADHD using stimulant medication and psychotherapy, as well as targeting other symptoms and issues related to the comorbid disorder. The treatment approach, of course, would depend on the nature of the comorbid disorder. Some writers, such as Barkley, have suggested that separate treatment approaches are required to address ADHD symptoms and comorbid disorders. This is where I think assessment has an important contribution to make. In recent years, assessment of adult ADHD has been discussed primarily by our neuropsychology colleagues. If you've looked at the workshops and scientific sessions offered at neuropsychology conferences for the past several years, presentations addressing neurocognitive issues in child and adult ADHD are offered regularly. These presentations are interesting and they're very valuable. What the material I've presented indicates is that mental health professionals in general, and psychologists in particular, should not conceptualize and assess adult ADHD only in terms of neurocognitive issues. Personality assessment has much to offer in this area. Let me be clear, I don't mean to suggest that in terms of assessment of adult ADHD, that personality assessment is more valuable than neuropsychological assessment or vice versa. From my perspective, what personality assessment offers complements what neuropsychological assessment offers and vice versa. When people talk about ADHD and treating adults with ADHD, the focus often is primarily on the difficulties that characterize ADHD, the problems with attention, self-control, impulsivity, organization, or time management. I'd like to suggest that this focus does not do justice to individuals like Joel who struggle with these issues. Instead, I'm advocating that we consider the ways in which ADHD characteristics are woven into the fabric of an individual's overall psychological makeup. Going back to the case of Joel, for instance, here's a guy that's bright and has a lot of potential. As a youngster, he heard repeatedly that he was not living up to his potential. Imagine what it's like for other youngsters with ADHD or Joel to get the message that they're lazy, or to have their parents and teachers become frustrated with them because they're not doing their work or not catching on. These messages can have a profound impact on a youngster. It's no wonder that the tension, fears of failing, and fears of disapproval highlighted by Joel's MMPI-2 profile are so much a part of his psychological experience, his approach to interpersonal relationships, and his functioning in the world. To state this as a more general principle, the experiences an individual with ADHD has as a consequence of difficulties with attention and self-control and the responses they get from other people because of these difficulties can have significant effects on their developing self-image, their social skills, their capacity to form interpersonal relationships, or their ability to regulate emotions. A comprehensive, integrated psychological assessment can highlight issues to be targeted in treatment in addition to the specific issues for adults with ADHD due directly to ADHD. An evaluation can inform a treating professional about the approach most likely to be effective with an individual, such as whether that person is most likely to respond to a directive or supportive approach to treatment. Assessment results can also clue professionals in who are treating adults with ADHD into how likely they're to be engaged in a treatment process and potential roadblocks to treatment. I'd like to suggest that the distinction between the simple, uncomplicated presentation of a disorder as opposed to the complex, complicated presentation of an order can be applied to conditions other than ADHD. For instance, I regularly see patients with chronic pain disorders. For many of these patients, dealing with pain and changes in functioning are the problems to be addressed in treatment. Other pain patients present both with pain and with depression, anxiety, or anger, or they may abuse alcohol or prescription medications. In his workshop yesterday on trauma and the MMPI-2 RF, Paul Arbisi similarly described different reactions to traumatic events. The reactions, the problems experienced by some people who have experienced significant trauma are limited to the direct effects of the trauma, while other traumatized people may be demoralized, depressed, angry, or abuse alcohol and drugs. The distinction between simple and complex presentations of a disorder has implications, I believe, for the practice of psychological assessment. We are all aware of the pressures and limitations placed on assessment practice by the entities that approve and pay for psychological assessments. Reimbursement for personality assessment has decreased. We've all felt the pinch. Payment, of course, depends on having an evaluation be approved. There are more limitations on when and why an evaluation is approved today than even a few years ago, and certainly more limitations today than when I started practice in the 1980s. The distinction between simple and complex presentations of a disorder suggests the following. First, not every individual with a specific disorder, such as adult ADHD, PTSD, or a pain disorder, require a full, comprehensive psychological evaluation. I'm sure insurance companies would cheer to hear somebody say that. As I noted earlier, for instance, 25 to 50% of adults with ADHD have simple, uncomplicated ADHD. That is, ADHD with no comorbid disorders. The general principle here, in terms of a cost-benefit analysis, is there's not much to be gained from a comprehensive evaluation for individuals who fall in the simple, uncomplicated group. The cost ratio benefit for individuals who fall in the complex group changes, however. This is where a comprehensive evaluation pays off. I would argue that it's a disservice to the 50 to 75% of adults with ADHD with complex, complicated ADHD, or a complex, complicated pain disorder, or complex, complicated PTSD to not have a comprehensive psychological evaluation. One significant challenge to the future of the community of psychologists who provide service, who teach, and who research psychological assessment is the extent to which assessment services are recognized, respected, and paid for. It's our responsibility to educate the public, our colleagues who are referral sources, and the gatekeepers who approve, authorize, and pay for assessment services about the value of comprehensive psychological evaluations. It's our responsibility to demonstrate through research and clinical practice when and how assessments contribute to clinical decision-making and outcomes. It's also our responsibility to develop guidelines for practice that specify when a brief diagnostic evaluation is sufficient and when a comprehensive evaluation is needed. I hope that the distinction offered here between simple and complex presentations of a disorder contributes to making the case that, in the appropriate situations, comprehensive personality evaluations are meaningful, clinically effective, and cost-effective. Thank you.